All right, welcome everybody. We're going to start our ATS Critical Care COVID Training Forum. I want to thank everyone for joining us today. Please let us know in the chat box if you have trouble hearing me or if you have any questions at all. My name is Sushma, and we're going to get started. I'll ask you all to please mute your microphone so that we don't have any extraneous noise. All right, let's get started. Oh, 1 second. Okay, so just want to get started. This is our ATS COVID-19 Critical Care Training Forum, as I mentioned. For those of you that are new joining us, we have our Critical Care Training Forum every Tuesday from 8 to 9 p.m. Today's session is on how HIV and COVID-19 synergize, clinical, scientific, and public health considerations in caring for persons with HIV amongst the epidemic-on-pandemic. So today, I'm going to be moderating. Again, my name is Sushma, and we have three amazing presenters for us today, whom I'll go over in a moment: Boghuma, Moran, and Caitlin. This is our financial disclosures. So the learning objectives for today, I'll just go over them so everyone is aware. You know that we are CME accredited, so you can earn CME for participating today. So after participating in this activity, the learners will be able to describe the clinical characteristics and outcomes of persons with HIV presenting with COVID-19 disease, evaluate considerations involving the pathophysiology of SARS-CoV-2 infection among persons with HIV and how this may affect vaccine response, and discuss the future directions of HIV, SARS-CoV-2 scientific research and public health implications of the COVID-19 pandemic on persons with HIV. So to claim CME credit, we need you to complete our evaluation of today's forum. We'll put the survey link in the chat box later as well, but here is the QR code if you'd like to scan it now. And just so everyone is aware, we have been doing the COVID Critical Care Training Forum for several months now, actually since March. And we have several sessions that have been recorded and are available for free on our ATS website. These are just some of the sessions we have done in the past. So you can find all of these on the website and are available for viewing. Again, we have 20 CCTF episodes that are all posted on the ATS website. You can search for ATS COVID Forum, or here is the link as well. All right, we have some upcoming ATS COVID CCTF topics as well. We're going to do a session on COVID-19 and lung transplantation. We're going to do a session on vaccine development, ECMO, and COVID-19, and there are several more to come. These are just the CCTF, the chairs and the team of trainees and our amazing staff without whom none of this would be possible. All right, with that, we're going to get started. It is my distinct pleasure to introduce our first presenter of the day, Boghuma Titanji. Boghuma is an infectious disease fellow at Emory University. Boghuma grew up in Cameroon, where she did her medical training. And after graduating from medical school there, she worked in general practice for a couple of years and then got an MSc in Tropical Medicine and International Health from the London School of Tropical Medicine and Hygiene. She then got a PhD in infectious diseases from UCLA, and her PhD research is focused on mechanisms of HIV drug resistance and the impact of antiretroviral drugs on cell-to-cell spread of HIV. She's currently an ID fellow at Emory, and I've been very fortunate to work with Boghuma on several of the COVID clinical trials, including ACT 2 and ACT 3. So thank you for being here, Boghuma. We're happy to have you. Oh, you're muted.
Can you hear me now? Hello?
Yes, we can hear you now.
Yes. Thank you for having me. To get us off started, I would start by presenting two cases. The first case is the case of a 51-year-old male to female transgender woman with well-controlled HIV on antiretroviral treatment with a CD4 count of 873 and an undetectable viral load, who presented to clinic for her routine follow-up visit. On her presentation, she was complaining of flank pain that was ongoing for 2 days without any other symptoms. And because it was a routine clinical visit, we set up the patient for regular blood work after noting that her vitals were completely normal. Her physical exam only revealed left-sided CVA tenderness, and her labs were completely unremarkable. My immediate differential on seeing this patient was because she had presented with CVA tenderness, we were worried about renal colic, muscle strain, or referred pain. And we sent her for a CT Abdomen-Stone Protocol. To our great surprise, it returned with bilateral ground glass opacities at the lung basis. And this prompted us to get additional testing by way of an MP swab, which was sent for SARS-CoV-2 PCR testing. Her SARS-CoV-2 PCR testing came back positive. Fortunately, this patient continued to remain without symptoms and just got pain medication to manage her CVA tenderness and made a full recovery. The second case is the case of a 54-year-old man with HIV with multiple comorbidities. This patient was a resident in a nursing home and had been in a nursing home for 2 years after having a CVA, which left him with residual left-sided weakness. He was well controlled in antiretroviral therapy with a CD4 count of 387 and a viral load that was close to undetectable at 75. He presented to the emergency department after being noted at the nursing home as being febrile and hypoxic. And on presentation in the emergency department, he was immediately screened and tested for COVID-19. His COVID test came back positive. Unfortunately, the patient rapidly decompensated and was intubated for ARDS on the first day of admission and continued to decline steadily throughout his course. By the fourth day of admission, he had a severe acute kidney injury that required continuous renal replacement therapy. And by day 7, he had also developed additional complications in the way of an MRSA bacteremia. I'll just like to note that infectious diseases was consulted on the initial admission, and due to his impaired renal function, he wasn't a candidate to receive remdesivir or be enrolled in any of the trials that were ongoing at that time. Despite maximum supportive care, he continued to develop complications, and in addition to the MRSA bacteremia, also developed bacterial ventilator-associated pneumonia by day 8. He developed worsening sepsis and required vasopressor support, and unfortunately by day 14, had a PA arrest and succumbed to his illness. So these are the two cases just to illustrate some of the cases of people living with HIV that we have seen in our hospitals with COVID-19. And with that, I would hand it over to Dr. Collins for the next part of the presentation.
So I'd just like to thank you, Boghuma. That was such interesting cases. It would be really interesting to discuss them a little bit further. So I would like to introduce Dr. Collins, Dr. Lauren Collins, who will be discussing the clinical characteristics and disease course of people with HIV presenting with COVID-19. So Dr. Collins is an assistant professor in the Division of Infectious Disease at Emory University School of Medicine and works clinically at both Grady and Emory. She graduated from BU School of Medicine, completed her residency at Duke, and her research interests include HIV co-infections and comorbidities, access to HIV care, engagement, and health disparities. So thank you, Lauren, for doing this with us today.
Thank you very much. Can you hear me okay? And
Yes.
Slides are up?
Yes.
Okay. All right. First, I'd like to thank the organizers for the opportunity to speak with you guys tonight and highlight persons with HIV as a unique subgroup of patients requiring special considerations in terms of presentation and care of COVID-19. And would also like to thank Dr. Titanji for starting us off with two really excellent cases that illustrate well the clinical spectrum of COVID-19 from asymptomatic illness and kind of incidental finding in a way to multimorbidity resulting in prolonged hospitalization, including ICU and unfortunately death. So with that, I will move forward. And I just wanted to briefly start with calling your attention to why it's important to consider people with HIV as an important subgroup of patients with COVID-19 and really highlight the HIV epidemic in the US. There are approximately 1.2 million people with HIV in the US, and that includes 1 in 7 who are unaware, 14% of their HIV diagnosis. Importantly, as you can see on the care continuum here, only 64% of those individuals are receiving care as of the latest HIV surveillance report in 2016, and only 53% had HIV viral suppression, which unfortunately has significant regional variation. But I mentioned this up front just to call your attention to the fact that nearly half of people with HIV in the United States are at risk for poorly controlled HIV, including potentially AIDS sequelae, and even AIDS-related death. The other half is doing well and virologically suppressed. So when we think about people with HIV, they really represent a heterogeneous group of individuals with unique biomedical and sociobehavioral considerations that must be taken into account during a novel viral pandemic. So in terms of synergy, here are two maps by US county showing COVID-19 prevalence on the left and HIV prevalence on the right. And I think it very clearly demonstrates that there's significant geographic overlap, which may suggest that structural forces such as policies, poverty, and racism may be fueling to coalesce health disparities that unfortunately synergize in terms of COVID-19 and HIV. Importantly, in the southern United States, nearly half of new HIV diagnoses in 2018 occurred in the South. And so this has become known as an epidemic-on-pandemic, and again, just kind of prompts us to think about this population as particularly vulnerable in the setting of a pandemic. So there are a lot of different considerations in terms of thinking about caring for people with HIV and COVID-19, and they're highlighted here, starting with health inequity, age, ART or antiretroviral therapy, which I'll refer to as ART or ART, immune function, which we typically measure or evaluate by CD4 count as a surrogate of immune function in people with HIV, degree of HIV control, and then comorbid conditions. And we'll revisit this slide as we try to unpack the data that's available in terms of highlighting the various roles that these different factors contribute to COVID-19 presentation and outcomes. So first, I'd like to start with honing in on age and comorbid conditions, as we learned pretty early in the COVID-19 pandemic that these two factors are extremely important in terms of risk assessment for thinking about SARS-CoV-2 acquisition. So people with HIV are living longer due to ART. It's estimated by CDC that over half of people with HIV are aged 50 years or older. And in a recent analysis with among people with HIV and HIV negative controls with access to care, the overall life expectancy gap by HIV status is narrowing. However, comorbidity-free life expectancy by HIV is persisting in terms of a gap. And it's estimated that people with HIV live 16 fewer comorbidity-free years. So in this high-risk population of people with HIV, multimorbidity is not only increasing, but it's compounding over time, as you can see here from 2000 to 2009 in terms of the number of comorbidities affecting people with HIV. So of course, this begged the question early on, how does COVID-19 present among people with HIV? I just mentioned that half, at least in the US, are aged greater than 50. So for ID and HIV specialists, I think we were especially concerned early on considering how COVID-19 may clinically affect people with HIV. Some questions that arose are first, did people with HIV experience greater risk of SARS-CoV-2 exposure? Secondly, is COVID-19 disease more likely to be severe among people with HIV compared with the general population? And what if HIV is poorly controlled and or the patient has AIDS, considering that nearly half of the HIV population is at risk? And finally, could ART be protective against SARS-CoV-2? So we don't have answers to all of those questions just yet, and the field is evolving. So I want to lead with the caveat that the impact of HIV infection on the natural history of COVID-19 remains uncertain, but we will try to tease apart what we do know, and starting by turning to CDC.gov and their section on HIV and COVID-19, which again highlights that we're still learning about how COVID-19 affects people with HIV, but based on limited data, believe people with HIV who are on effective treatment have the same risk for COVID-19 as people who don't have HIV. And the CDC comments that older adults and people of any age who have serious underlying medical conditions might be at increased risk for severe illness, and this includes people who have weakened immune systems. So considering this, the risk for people with HIV getting very sick is greatest in people with a low CD4 count and people not on effective HIV treatment. So we will proceed to unpack the known evidence around these various issues and kind of can discuss together how accurate this guidance may be as the evidence base has evolved. So COVID-19 in persons living with HIV, what do we know today? This was the review of 8 published case series that was written by Dr. Carlos Del Rio, our astute Emory ID faculty, as the New England Journal of Medicine Journal Watch in August. And I just first want to highlight that in terms of the infection rate, it ranged, considering the base population of people with HIV in each region, from just under 1% up to nearly 3%, and that in terms of demographics and in terms of sex and age and race, those were on par with what we would expect for people with HIV in that region. And so all of these case series are hospitalized patients with COVID-19. So honing in on the HIV-specific characteristics, I want to draw your attention to the CD4 count and HIV viral load. And as you can see here, the majority of patients that were hospitalized with COVID-19 had a CD4 count that was greater than 350, so not considered AIDS. And the vast majority, so on the upwards of 80% to 100%, had HIV viral suppression, which is again much different than what we expect just in the general HIV population when considering the HIV care continuum. Finally, the number of comorbidities experienced in these initial descriptions of people with HIV presenting with COVID-19 illustrates that multimorbidity is high in this population, with a number of comorbidities ranging from 56% up to high 80s. So taken together, these data suggest that the risk of SARS-CoV-2 infection and severe COVID-19 may not be due to immunosuppression, but more so related to comorbidities, as mentioned earlier, potentially even socioeconomic status, and that risk and outcome might be comparable to the general population. So I want to hone in on this study from Atlanta as we contributed to those data, and it also illustrates well the role of comorbidities. So this case series was from all hospitalized patients with HIV who presented with COVID-19 as a confirmed case by PCR from 3 hospitals in Atlanta. And of 530 hospitalized COVID-19 cases, nearly 4% occurred among people with HIV. Median age was 57, 65% were men, and 85% were non-Hispanic Black. Median CD4 count was 425, and 90% had HIV viral suppression. Taking a deeper dive into the comorbidities, we looked at the comorbidities listed here, and you can see most commonly were hypertension, dyslipidemia, and diabetes, ranging from 45% up to 70% of patients. We also looked at overall comorbidity burden, defined as the total number of comorbidities prior to admission. And as you can see here, half of the patients had at least 5 comorbidities. And interestingly, of all 3 patients who died, CD4 count was greater than 200, and all had HIV suppression, and each had 5 comorbidities. So a different population than we would have thought could be hospitalized for COVID-19 and affected kind of at the onset of the pandemic, and even considering the earlier CDC guidance. So turning to a study out of Boston, which was not one listed in the table, but it was published subsequently. This study included 36 patients confirmed COVID-19, all having HIV, again out of Boston, from March 3 to April 26. And nearly 85% had a comorbidity associated with severe disease, primarily in this population, obesity, cardiovascular disease, and hypertension. The vast majority of patients in this case series as well had a CD4 count greater than 200, and nearly all were prescribed ART. This group also looked at exposure history, and nearly half of patients had exposure to congregate settings, such as a nursing home or assisted living facility, and an additional third of patients were considered frontline workers, either in a home healthcare setting or in retail or the grocery store, for example. Importantly, 77% were non-Hispanic Black or Latinx, and this compared with 40% of non-Hispanic Black or Latinx that comprise their HIV clinic population. So these final pieces really take a nod to the role that health inequity likely plays and is synergizing among people with HIV in terms of COVID-19 risk and outcomes. So what about data that compares people with HIV to those that do not have HIV? So all of the studies I've presented so far were just among persons with known HIV infection. But the question really is, do HIV individuals or people with HIV have a higher risk of acquisition of COVID-19 or higher likelihood of developing severe disease? So there are ongoing studies in the US to examine this question, and several in preprint from Europe. However, I did want to call your attention to this one published study in CID in late August, which was a population cohort study in a high burden HIV setting, the Western Cape, South Africa. So including, including 3.5 million patients, 16% with HIV from March 1st to June 9th, over 22,000 were diagnosed with COVID-19, of whom nearly 3% died. Looking globally, HIV was independently associated with COVID-19 mortality with an adjusted hazard ratio of 2.14, and similar risks were observed across strata of viral load and immunosuppression. Importantly, this study also looked at current and previous TB, and they were associated with COVID-19 death. So I mentioned this study because it illustrates the need for more data, especially in US and other settings, in order to compare people with HIV to those without HIV, considering SARS-CoV-2 risk and COVID-19 outcomes. There's been a lot of discussion about this study, which we may get into in the Q&A, which basically revolves around the fact that potentially these risks are slightly overestimated when considering potential confounders such as comorbidities that were not captured in adjusted models. So in thinking about all the factors we mentioned earlier that may contribute to a COVID-19 risk and presentation among people with HIV, I think we've made a strong case for the contribution of comorbid conditions and health inequity. I think HIV control and immune function may be a de-emphasized contributor. However, Dr. Moran will elaborate on these farther. And I briefly wanted to talk about the role of ART, as it's been hypothesized that some antiretrovirals in particular may be effective against SARS-CoV-2. It's very possible that you guys have already discussed this study in this forum because it's from much earlier in the pandemic, but is still, I think, one of the better studies highlighting kind of the repurposing of ART. So this was the randomized control trial published in New England Journal that included nearly 200 patients evaluating lopinavir-ritonavir versus standard of care in adults hospitalized with severe COVID. Primary endpoint was time to clinical improvement, and other endpoints included 28-day mortality and SARS-CoV-2 viral load. As you can see here, there was no benefit observed beyond standard of care in the lopinavir-ritonavir group, and neither was there any difference in terms of SARS-CoV-2 viral RNA load that was obtained by throat swabs. Similar findings have been shown among hospitalized patients that were studied in recovery. So it seems like there is limited role for lopinavir-ritonavir in terms of use against SARS-CoV-2, at least in human studies. What about ART among persons with HIV specifically? So this study out of Spain reported on the incidence and severity of COVID-19 in HIV-positive persons receiving antiretroviral therapy. They included nearly 80,000 people with HIV on ART at 60 Spanish hospital-affiliated HIV clinics from February 1st to April 15th. 236 were diagnosed with COVID-19, 151 were hospitalized, and 15 were admitted to the ICU, 20 died. This group estimated risks of clinical course based on ART regimen and specifically looked at the NRTI backbone, which is the nucleoside or nucleotide reverse transcriptase inhibitor. What they found was that risk of COVID-19 diagnosis and risk of hospitalization was lowest among those who were on TDF M-tricytidine compared with all other NRTI combinations. TDF, or tenofovir, and tricytidine, as listed here, is what is used for HIV PrEP or prophylaxis, also known as Truvada. It's important to note that we rarely use Truvada as a backbone in an ART regimen for people who have significant comorbidities because of the newer tenofovir known as TAF, co-formulated with M-tricytidine, is called Descovy, which has a better side effect profile, at least in regard to renal and bone disease. The Descovy side effect profile is evolving, and we don't have time to discuss that further, but suffice it to say, this study kind of came under some heat because potential confounders were not accounted for, including comorbidities and institutional prescribing practices. And again, happy to discuss that more in the Q&A. So taken together, while certain antiretrovirals have been hypothesized to have efficacy against SARS-CoV-2, supporting data are lacking, and ART regimens should not be adjusted based on concern for COVID-19. So wrapping up this portion of the talk, I just wanted to consider all of these factors together and highlight guidance by IDSA and HIVMA, Considerations for People Living with HIV, which is a great resource that can be easily found online. And summary from this statement is listed here. So first, HIV status or HIV control should not influence medical decision-making regarding clinical trial enrollment for COVID-19 or access to life-saving interventions. Heightened awareness for severe disease should be considered for those with multimorbidity, low CD4 counts, or HIV viremia, or HIV that's not controlled. In the context of the data that we reviewed, I think this is mostly out of clinical concern compared with a supporting evidence base. However, future studies are needed. Consultation with ID or HIV specialists is highly recommended, and the document includes both a warm hotline and a warm line, and a hotline that can be accessed during kind of regular working hours or otherwise. ART should be continued during hospitalization without interruption. And then finally, drug-drug interactions between COVID-19 treatments and ART should be considered. And there's a really phenomenal application that can be used that is dedicated to COVID-19 drug interactions in the context of ART, including through the University of Liverpool. So with that, I think I hopefully have left you curious about implications of these data among persons with HIV and next steps. And I will turn it over to Dr. Cribbs to introduce our next speaker. And thank you for your attention.
Thank you so much, Lauren. That was excellent. We did have several questions that came up in the chat. So I thought since these were directed at you, maybe we could ask some of them now. And if you feel like it would be better answered at the end, we can put them aside. So some of the questions that came up is, someone asked, does the viral load of COVID, is it more in HIV than in non-HIV patients? I guess the viral load of COVID is what they had typed in, but I'm assuming that means
yes, so that is a very good question. I have not yet seen data on SARS-CoV-2 viral load and if that may differ among people with HIV, but interestingly, that is something that our group is hoping to study, so maybe we can report back. And if other presenters have input, please feel free to weigh in.
Okay, and then a couple of other questions that came up. If there was morphological or radiological changes in COVID-19 patients, in non-HIV COVID-19 patients versus HIV patients with COVID-19, if there were any distinctions between those two groups that you saw clinically.
That's a good question. So basically, do radiographic COVID-19 findings differ between people with and without HIV? Mm-hmm. So yes, that's a very good question. I think that the actual clinical presentation among people with HIV is not seeming to be that different compared with the general population, both in terms of symptom duration, vital signs, exam findings, including. I think that, you know, it's, and at least I can speak to our study in Atlanta. And again, a lot of the data that we have currently are like initial descriptions or case series that are single site. About half of the individuals, or slightly more than half, had chest x-ray abnormality, and very rarely was it like a lobar infiltrate. It was more kind of diffuse hazy findings, I think, which would be consistent with more of the general population presenting with COVID-19.
Okay, thanks so much, Lauren. There are a few more questions, but I think we'll move on to Caitlin's talk, and then we can come back to some of those questions at the end. So it's my distinct pleasure to introduce our next speaker, Dr. Caitlin Moran. So Caitlin is an assistant professor in the Division of Infectious Disease at Emory as well. She went to medical school at Georgetown, completed her IM residency at Pittsburgh, and then came to Emory for her ID fellowship, and we were lucky enough to keep her. She is going to be discussing HIV and SARS-CoV-2 co-infection science and public health implications. Caitlin is also very involved in HIV and COVID research, very interested in non-infectious complications of HIV, and I've had the distinct pleasure in working with her as well. So thank you, Caitlin, for joining us today.
Thank you, Sushma. It's great to be here. And I'm very excited to talk to you all about the implications and the research going forward of SARS-CoV-2 infection in people with HIV. So I think Moran is still driving the slides, so if you could go ahead. It's great. So you know, we talked about a lot of implications or a lot of different factors that can influence COVID-19 among people living with HIV. So I would like to take a deeper dive into the role of immune function and CD4 count among people living with HIV. So before we do that, I just want to take a little bit of a closer look at the immune response to COVID-19. So as you all know, SARS-CoV-2 is a coronavirus that basically attacks respiratory epithelial cells. It invades the cell and sets off kind of this cytokine pathway that's mostly a Th1 response and produces a lot of Th1 cytokines, as you can see in the figure over to the right. Next slide. And so from there, the body can really do one of two things, and this is, you know, pretty well documented at this point, that, you know, SARS-CoV-2 infection can really go one of two ways, that you can have this fairly, you know, mildly symptomatic or even asymptomatic COVID-19 infection, or you can have this really dysfunctional immune response and cytokine storm. So taking a look first at the kind of normal reaction or kind of the healthy immune response, it's where you have activation of CD4 T cells. The CD4 T cells will mediate the immune response in the production of neutralizing antibodies. At the same time, they will also stimulate a CD8 T cell response, which is a cytotoxic response. And so you'll kind of get this synergy where the neutralizing antibody will bind and inactivate the virus, and that the cytotoxic T cells will and innate immune cells will kind of clear up the neutralized virus, and you're done with that. Unfortunately, what can happen, and we don't fully understand why this happens in some people and not others, is this cytokine storm and this kind of dysregulated immune response. So there can be this kind of dysregulated response where there's leakage caused by vascular permeability from this really strong influx of cytokines and maladaptive influx of cytokines. And really the antibodies produced are non-neutralizing and can actually even cause worsening infection. And so this is really just an excessive production of cytokines in the innate immune response, leading to pulmonary edema, pneumonia, ARDS, and multi-organ damage. And importantly for our talk today and for people with HIV is that this, it's really driven, a lot of this immune response is really driven by the CD4 arm of the immune system. So it's really the CD4 positive T cell activation that drives the production of the inflammatory cytokines that triggers the immune response more towards that Th1 response and producing a lot of cytokines like IL-6, TGF-beta, interferon gamma, that will stimulate the immune system. And in many ways, this is important, and this is important for production of neutralizing antibodies. However, the system can also kind of go haywire if it's overexpressed or overstimulated. Next slide. So this is really important because HIV infection results in CD4 T cell depletion, which I think we all know that the main target of the HIV virus is the activated T cell. So when someone is first infected or someone is first exposed to HIV, the first cells that are infected by the virus are their activated CD4 T cells, mostly in the gut-associated lymphoid tissue, before the virus can then replicate in those CD4 cells and kind of disseminate through the body. If you could just click one slide. Thanks. And then the next thing that happens is that the HIV virus can also infect thymic precursors, which is really important for T cell regeneration. So if you have infection of your gall and depletion of the CD4 T cells there, as well as in the thymic precursors, even if you get back on ART at a later date, your T cells, your CD4 cells can't always regenerate up to where they were prior to HIV infection. At the same time, you have this kind of ongoing level of T cell activation, all of which, as you can probably tell, can have an impact on your immune response to other infections, including viral infections such as with SARS-CoV-2. Next slide. Interestingly, we're just starting to learn about some of the clinical implications of the immune response to SARS-CoV-2 in people living with HIV. This is a study that just came out a few weeks ago from Italy, and this was a case series of 5 patients who were in an Italian hospital in April and May, and these were actually, I think, the only patients living with HIV who had been hospitalized there during their large outbreak in Italy. And so of these patients, I'd like to walk through a little bit of their clinical characteristics because I think this illustrates some important points. Patients were mostly older, although there was one young transgender woman in her 30s, but the rest were men in their 50s and 60s. Again, 4 out of 5 had pretty good CD4 counts. One was a little more immune suppressed with a CD4 count of 127. All had suppressed HIV viral loads, although patient 4, who also had the low CD4 count, had just achieved viral suppression within a month or so of admission, so had just been on ART for a few months. They had a wide range of symptoms. Patient 1 in particular had more serious symptoms, as well as patient 2 with fever, cough, myalgias. And then patients 3 and 4 were asymptomatic. All had some changes on lung imaging, mostly bilateral ground glass opacities, although 1 patient had focal pneumonia. 2 out of the 5 required supplemental oxygen. Many received hydroxychloroquine. Interestingly, patient 1 also received tocilizumab, which is an IL-6 monoclonal antibody, as well as methylprednisolone. And then all patients, except for patient 4, were found to have developed neutralizing antibodies to SARS-CoV-2 at neutralizing titers. And so interestingly, in the figure on the right, what you can see is that the immune response to the spike protein on the virus, which is in the white bar graph, was fairly robust in some of the patients, although much less so in that the 1 patient with a lower CD4 count. And then again, neutralizing antibodies were produced. Interestingly, though, when you look at CD4 and CD8 T cell activation, that actually patient 4 and patient 5, who had fairly minimal neutralizing antibodies, actually had the highest production of, or highest activation of their CD4 and CD8 cells. And then finally, looking at different cytokine releases, it looked a little different, just depending on the patient. So, this is a small case series. We're hoping that some of these data are going to start emerging from some of the larger cohorts, and we can learn some more. But I think this just illustrates that it's a very heterogeneous group, and someone who looked like they were maybe a little more immunosuppressed, who didn't even, maybe mounted less of an immune response, was actually asymptomatic and had a really uncomplicated clinical course with their COVID infection, where someone else with maybe a more reconstituted immune system didn't. And so just to demonstrate that it can really, really vary. Next slide. So the other implication here is for vaccine response. So we have a lot of vaccines that are currently in development, a lot of trials going on, a lot of phase 3 trials going on. And walking through the various vaccine platforms, what does it mean? I mean, we have evidence that people with HIV are able to, for the most part, mount neutralizing antibodies. Of the vaccines that are currently in phase 3 trials, which are these first 4 in phase 3 trials in the US, there are some in other countries as well. All of them do include people with HIV. They're not excluded from the study. They have various inclusion-exclusion criteria, but for the most part, all patients living with HIV who are enrolled in these studies have to have well-controlled HIV with a CD4 count over 200 at least, some over 300 or 350. The Novavax study is coming out soon. I haven't seen the protocol yet for that one, so that's going to enter phase 3 trials soon. And I believe will also include people living with HIV, and the Merck vaccine is still in preclinical trials. So I'm glad that the people living with HIV are included in these vaccine studies, and we should have some more information soon on whether they're able to develop neutralizing antibodies as hoped. Next slide. However, we do know that HIV infection in and of itself can blunt vaccine response and the duration. So this is a study that was done in children, and it was looking at infants who were born either unexposed to HIV, which is in the gray bar, infants who were born with HIV and placed immediately on antiretroviral therapy, those who were born with HIV and placed on antiretroviral therapy after some delay, and that's in the light blue. And then in the red are infants who were born, who were exposed to HIV but were unaffected. So their mothers had HIV, but they were HIV negative at birth. And so the graph on the left is immune response to the tetanus toxoid vaccine. And the graph on the right is to the hepatitis B surface antigen. And so what you can see is that pre-booster for the tetanus vaccine, there were pretty low levels or basically no levels of neutralizing antibodies. And then after the vaccine, all were able to mount some vaccine response, although it was certainly higher in the HIV negative children compared to the HIV positive, and that response waned over time in all groups. And then the graph on the bottom is looking at percent who had kept their neutralizing titers above threshold. And you can see basically in the immediate post-booster, pretty much everyone did, although starting to fade off a little bit in the delayed ART group. And then similar responses were seen to the hepatitis B. The Hep B vaccine is given at birth, so this is at 5 months, 15 to 18 months, and then 24 months old. So just to point out that there is a concern that when a SARS-CoV-2 vaccine is developed, that people living with HIV may not have as robust an immune response to that vaccine as the general population. So then another area that is important to look at, and that is being actually a big area of research right now, is HIV control and health inequity, and how care is delivered to people living with HIV during the COVID-19 pandemic. And this isn't much different than for other chronic diseases, but I like to use HIV as a model. Dr. Collins showed this slide a little while ago, but this is the HIV Care Continuum that you can look at either based on the percent of patients who are diagnosed or who have been diagnosed and received care. And just to note that there is a drop kind of at every step in the care continuum between diagnosis and receipt of some care, and then retention in care, resulting in about 53% of people living with HIV achieving viral suppression at any given time in the US. Next slide. And the COVID-19 pandemic has really altered this. There are a lot of kind of descriptive studies and kind of perspectives written about this, although it hasn't really been rigorously evaluated. But various issues such as stay-at-home orders, resulting in a huge uptake in telehealth that some health systems maybe just weren't as well prepared for. Really vast reorganization of pharmacy services and how people get their meds. Ryan White and ADAP are programs that pay for HIV care. Ryan White for kind of clinic and hospital-based care, and ADAP is the for HIV. For antiretroviral therapy, it's the AIDS Drug Assistance Program. And normally these programs require, depending on the state, require patients to re-enroll and have blood work every 6 months. And if they can't physically come into clinic, what happens to their healthcare access? And then other issues related to STI screening and treatment and mental health, and just a whole host of other issues related to HIV care. This is one study that was, again, out of Italy, and it looked at the effect of the COVID-19 pandemic on HIV care delivery in their clinic. And they basically compared what happened between October and November 2019 with what happened in March and April of 2020. And overall, the circle graph on the top shows the October to November time, and they had, of their visits performed, they had 95% of their visits were performed, which is a level I have yet to achieve in my clinic, but they were able to get 95% of their visits performed in that 2-month period. Between March and April, they only saw about a quarter of those patients in person, although they did see another 67% or so through telemedicine, but they did see a drop off in percent where about 8% didn't make a visit at all. And this differed a little bit by sex, where women were more likely to miss visits during the COVID-19 pandemic than men. And then non-Italians also more likely than Italian nationals to miss visits. Interestingly, it looks like there wasn't a huge drop-off in clinic attendance or through telemedicine, but overall there was about a 23% reduction in antiretroviral dispensation from the pharmacy in March and April compared with October and November, suggesting that about a quarter of patients weren't receiving their medications as they should. Next slide. However, despite all these interruptions or disruptions in care, it does give us the opportunity to reimagine HIV care delivery, going from really a hospital or clinic-based model to a more community and patient-centered-based model where you can, see more flexibility with providers and with pharmacy services and kind of community-based or mobile health integrated services that hopefully will be able to reach more people living with HIV and try to get them engaged in care. So I think this is an opportunity for us to kind of understand what is going on, first of all, and then get people more engaged in care during the COVID pandemic. Next slide. And then finally, this is a perspective piece that was written recently looking at community health workers. And so just bringing other people into not necessarily physicians or nurses or pharmacists, but bringing other people from the community in to address some of these social determinants of health that are so important in HIV care and care for a whole host of other chronic diseases. Next slide. So there's a whole lot of ongoing research and a lot of questions, and I think we've probably left you with more questions than answers at this point. But what's going on right now is we really do need larger cohort studies to determine the impact of HIV on COVID-19 outcomes. And these cohorts exist, they're being built, and patients are being followed, but some of these data, COVID-19 is so new that we just don't have all of the information just yet. There are studies ongoing looking at the impact of HIV on COVID-19 immunology. So what COVID is, what happens to the immune system after a COVID-19 infection, is that different based on the presence of HIV infection or the level of HIV immunosuppression? Another interesting thing is this impact, the idea that COVID-19 can actually impact HIV viral dynamics because COVID-19 does result in some lymphocyte depletion, and can there be some viral escape even in patients on ART? I think it's critically important that we continue to enroll people living with HIV and COVID-19 treatment and prevention, including vaccine and monoclonal antibody trials, so that we can understand first of all, for equity reasons, but also so we can understand how these treatments affect people living with HIV. And then also look at the effects of the COVID-19 pandemic on the HIV care continuum and HIV outcomes. So a lot of these studies are ongoing. So in conclusions, just to wrap up for the entire talk, people with HIV appear to have similar COVID-19 outcomes compared with the general population, but more data are needed to inform best care practices for people with HIV with COVID-19, including improved understanding of the role of age, comorbidities, HIV control, immunocompetency, ART, in COVID-19 risk and outcomes. And the presence of HIV infection, nor the degree of HIV control should affect access to clinical trial enrollment or triaging of potentially life-saving therapies. And finally, the pandemic has evolving public health and health services delivery implications for people with HIV. So with that, we will wrap up and are happy to take any of your questions.
Thank you so much, Caitlin. That was excellent. All three of you, it was really great. We do have several questions that came in. Before I read them though, I just want to say I'm really excited to see that HIV patients are not being excluded from these vaccine trials. I feel like in so many clinical trials, HIV is either an exclusion or there's some caveat to that. So to me, that's just really nice to see from that perspective. I wonder, given your slide about how vaccines affect HIV patients and that there might be potentially a lower vaccine response, is there going to be some way to kind of tease that out in these large vaccine trials, or what do you guys think about that?
Yeah. I mean, that's a great question. I can say from my experience working with one of the trials, the Moderna trial, which we're enrolling right now, the HIV, it was actually had to be an amendment. There was a lot of advocacy that went into including people living with HIV in that trial. And so they were kind of late to start enrolling people with HIV in that trial. I think subsequent trials have included people with HIV from the beginning. So I think the enrollment numbers overall will be fairly low. All the clinical trials are, there are no HIV patients were enrolled in the phase 1 or 2 trials, so we don't have the early clinical trial data on them. We do, hopefully there will be some analyses of the immune response. Most of these trials are following patients out for 2 years. So hopefully we'll be able to study the immune response in a small subgroup. So hopefully we'll have some information on that.
That's great. All right, well, I want to make sure I get to the audience's questions. So I'll just kind of start from where we left off. One of the questions, do patients with HIV and COVID-19 remain infective for longer than 20 days, which is what the CDC is recommending for critically ill patients, as you know? I guess for as far as isolating them.
For immunosuppressed.
Yeah.
So that's the CDC cutoff for immunosuppressed or critically ill patients. As far as we know, we don't think they do. I think the patients who have received organ transplants or are undergoing chemotherapy, they're probably even more immunosuppressed, and we haven't seen infected virus beyond that 20-day mark. So I haven't seen any data that suggests that people with HIV would have infected virus for longer than that.
Okay. Let's see. Does recovery from COVID-19 take longer? I guess that kind of answered that same question. Is there any evidence of COVID-19 reinfection in people with HIV that any of you are aware of?
I haven't seen anything published yet, but there have been case reports in non-HIV infected people. I'm sure as we move into the fall and we start seeing an uptick in cases, maybe some of these case reports might emerge in our people living with HIV population. But I haven't seen anything.
Okay, I agree with that one. If a patient with HIV and COVID-19 is considered a percentage. So I think this was a translation from someone, so let me make sure I get it right. I think someone was asking about the percentage decrease in CD4 count that you would see in an HIV and COVID-19 infected patient, that you might see in the hospital maybe, it says compared to a patient who only has COVID-19. I don't know if that's
yeah, so it's a good question. This is hard, right? Because we're not usually measuring CD4 counts and percents in people who don't have HIV. Right. So we know that COVID results in lymphopenia in general in a lot of severely ill patients with COVID-19. We don't necessarily look at CD4 specific T cells in those patients, so I don't know for sure. Yeah, we do tend to see a drop in CD4 count in any HIV patient who's critically ill. That is generally not clinically significant. It doesn't necessarily put them at immediate risk of an opportunistic infection when that happens. But I haven't seen any data that actually look at CD4 counts and percent in the general population.
Sure. Well, I guess along those lines, one of the questions was, what are the possible drug-drug interactions between antiretroviral drugs and COVID therapeutic drugs? And I know, Lauren, you posted a website about interactions, but I guess anecdotally, or if you think of that when you're consulting on these patients, anything you can point the audience to that they should be aware of?
That's a good question, and I don't know of any off the top of my head. I don't know if Caitlin or PK are aware of any, but I think just would recommend the Liverpool app for anything of concern and just to be extra sure.
Okay. And then someone asked, is there a difference in morbidity and mortality in patients with HIV when they get COVID-19 in comparison with the general population?
So that's a great question. I think that the jury is still out. I think that generally the data that are currently available suggests that for people with HIV that get COVID, they're doing just about the same as the general population. I think that the study mentioned from South Africa did show increased mortality in people with HIV, but I think there are a lot of caveats to that study, including consideration of socioeconomic status and comorbidities that couldn't exactly necessarily be adjusted for and will be important. And again, it was a high burden setting, so very important to consider. But I do think more data are needed. But in general, what we're seeing is, at least from the case series presented, which again need controlled for, that outcomes seem to be the same.
And then someone was wondering about the effectiveness of convalescent plasma in COVID HIV patients. And are there any considerations to think about there?
Go ahead, BK.
I was just
Boghuma smiling, so I knew she was going to answer that one.
I think the considerations are pretty much the same as for non-HIV patients, and we don't even have proper randomized clinical trial data yet to even speak on the efficacy or lack of efficacy of convalescent plasma in patients who are not HIV positive. And I think that for those trials would have to include people living with HIV to actually have an answer to that question. So right now, we don't know that there's a difference.
And then one final question that came in is about children living with HIV and some of the, I guess, the multi-system inflammatory syndrome. Has that been shown in children with HIV, or has there been any data from that perspective? Any thoughts on that from
you're
our
looking
adult,
at three people who
from
are
our
not
adult
pediatricians.
from our adult ID doctors?
There are no pediatricians in this panel, so I haven't seen anything, but I would not be an authoritative source.
I haven't seen anything either, actually. So as far as that's concerned, I think the jury's still out. Hopefully people will remain safe. I actually just had a question as far as have you seen many people with HIV who have gotten COVID-19 in your clinic? And does there seem to be any specific type of organ dysfunction or sort of something that seems to be striking to you that patients seem to be receiving as far as people with HIV compared to non-HIV after COVID, or has it been about the same as far as just anecdotally what you've been seeing in your clinics?
I mean, in my patient pool, I have seen a couple of HIV patients who've had COVID and recovered. And anecdotally, in that group, I haven't really seen any differences. They've made a full recovery and they've come back to their clinic visits. Some have residual fatigue for a couple of weeks, but then when I've seen them on subsequent visits, they've been back to their baseline. But that's my experience, and maybe Lauren and Caitlin have different experiences as well.
Yeah, I've had very similar experience in my clinic too, of my patients who've had COVID. Most have remained out of the hospital and done well as outpatients and recovered fully. That's
great. That's nice to hear. Someone did post about reports of multi-inflammatory syndromes in adults. And I did actually just see recently there was a MMWR that came out about multi-system inflammatory syndrome in adults. So just recently published. I could try to send that out to somebody. That seems to be being reported in adults as well as children lately. So I don't know if you all have any other comments about that, but I did just read about that today. I saw something that came out not too long ago, and it's not MIS-C. Anyway, it's mostly in young adults, or it's been described in 20-year-olds. I imagine it's the same syndrome. We're just seeing it in young adults as well. Yes, agreed. Okay, well, it's 9:06, and I don't see any other questions. So with that, I'd just like to thank our three speakers. Thank you guys so much. This was very informative. There are a lot of thanks coming through the chat box. So I really appreciate you guys taking time out of your very busy lives to do this for everybody. So thank you again.
Thanks so much for having us.
Thanks for having
No
us.
problem. All right. Bye, everybody. Good night.
All right.
Take
Thanks,
care.
everyone.
Thank you, guys. Bye-bye.